just to continue, these are just several things that are serious health conditions that you want to be aware of, that the patient who is obese is likely to have these associated ailments, or obesity itself may be a partial cause to these problems. And so it's just kind of, being aware of when you're looking at a patient that's obese, you really want to evaluate fully all the potential complications or chronic diseases that might be associated with obesity. So treatment or management of the obese patient, of course, is going to also include physical activity. A long-term goal for all patients with obesity should be to be able to have moderate intensity exercise most of the days of the week, 30 minutes a day. Some of these patients have not had that much activity, and so they have to build up to that, but that is definitely something that you want them to be able to accomplish. Behavioral therapy, some things that they do with that is they may have you start to document exactly what food you ate and when and how much. And so it starts to make you really more accountable for what you're eating and more aware consciously to make true cognitive thinking about how best to eat, not just that you eat as things come to you, but that you have more of a control. And it's to kind of identify, are there stimuli that make you really eat uncontrollably, and how to put those into perspective. And then having them in a good social support group has been found to be very helpful as well. These are just a few medications. They're not on the test, but just to be aware of. Patients that do go to weight loss centers a lot of times will be placed on one of these 3 drugs. The last one in particular is supposed to only really be used based on the FDA for up to 12 weeks, and often you're going to see patients are left on this drug for a long period of time, because in some of the other ones too, they will lose weight and have their appetite controlled, and then at the end of that they'll come off of the medication and maybe gain quite a bit of weight back, and then they go back and then they end up back on it. So you may see some patients that will indicate to you that they just couldn't get things under control. But the whole point of the medication is to kind of give them a jump start, so that while they're having this help with appetite suppressant drugs, then they are reformulating the kind of diet they need to stay on, and develop a new habits in terms of exercise and things during that time period, and that they lose weight pretty well on the front end, and then trying to sustain and or keep that weight off at the end of this means that they really have got to adapt and change to the new way of eating and stay with that without the help of the appetite suppressant. This is the list of some types of surgeries that can be done for the bariatric patient. And complication rates for death are fairly low when you think about the risk of death for patients that are highly obese. That has improved, because when these type of surgeries first started, a lot of times not many doctors were doing them, and so there's been a learning curve. But at this point, there is a mortality rate, so it is something to pay attention to, but it's not terrifically high by comparison to how serious the obesity might be and its impact on them. Just some pictures of how some of these are done. You can kind of see with this is a restriction type procedure where they've put a adjustable band on here that can be tightened or loosened, and it kind of creates a small stomach pouch, and only allows a little bit in there at a time, and then allows it to kind of flow on and out through the stomach. So it's still going through the stomach here, but it really is controlling how much can be eaten at one sitting. Then there's some other types that are like bypass surgery, which this is a picture of, and there's some malabsorption surgeries as well. But the gastric bypass is a pretty common one. You see here where a bypass graft has been put that kind of goes from the end or the upper part of the stomach, the end of the esophagus, down, and just bypasses completely the stomach. And that stitched area at the top of the stomach there is completely closed off. So in this case, you only have food going just in that little upper part of the stomach and then bypassing around. So really tiny, tiny amounts of food and or liquid can be taken in, and not as much is going to be absorbed because of that. And that applies to lots of things you have to be aware of, like medications. A lot of these patients aren't absorbing enough of the nutrients from the food that they are eating, so they nearly all have to be on a lot of vitamin supplementation, or their vitamin levels will drop drastically and have some symptoms associated with that, like hair loss and different things that you don't normally see in people that are eating regular food. This is just a nice link if you're wanting to know a little bit more about how a patient, what they'd have to do or what services are available. This is a link to the one at Novant Health down in Winston-Salem, and you can kind of look through that just at your leisure. These are some nursing interventions that you really need to commit to memory, because this is kind of the heart of how we care for somebody with after a bariatric surgery. They nearly always have an order for an abdominal binder, but they're very large patients. And nowadays, sometimes you can actually have specialty abdominal binders available, but at times you're going to work on an area where you may have to put two abdominal binders put together to make one almost, because of the size of the abdominal girth of the patient. And then, you want to be careful about positioning with these patients. You want them to be a little bit more in an upright position if possible, for their, not only for their breathing, but also because a lot of them come back with a nasogastric tube after surgery, and that means that they are going to have to be, kind of in a still position where they're not pulling out anything. You can imagine that patients that are already obese sometimes will have some difficulty breathing because of the things we've talked about with sleep apnea and the fat around the neck. Also, just abdominal fat pressing down on the diaphragm can make it where they're not taking as deep a breath as somebody else. And then when you try to put them under anesthesia, they are at much bigger risk for hypoxia and atelectasis and a lot of the respiratory complications after surgery. So they want them always on continuous O2 monitoring. They're going to always order sequential compression hose, and those need to stay on the patients all the time, post-operatively up till discharge. And they're going to be on DVT prophylaxis meds like Lovenox or heparin sub-Q injections. And don't be surprised if these patients are ordered on a larger dose because of their body size. A normal daily dose of Lovenox for preventive might be 40 milligrams sub-Q, but because of their size of their body, sometimes they'll increase the dosages on these patients, to maybe 60 or 80 milligrams just because they need it to be because of their size. Of course, skin assessment is an ongoing issue. A lot of these patients already have skin rashes, yeast infections in their skin folds that are all pre-surgical problems of the obesity. So we watch all those real close. We may watch them for skin breakdown. And they need absorbent padding in the areas where sweat might gather and might be making it more likely to have yeast infections. It is recommended to take out their catheter in the first 24 hours. So you do have to, again, have that bariatric bedside commode already available and ready to go for that process. And when you assist people out of the bed and ambulate as soon as possible, a lot of times you're doing that in collaboration with several people on the unit because of their weight. You want to be very careful and have enough people to assist. And physical therapy is going to always be involved, usually, to help with that process. There is standard to measure the abdominal girth, and that's just kind of making sure that there is no complications in the GI tract or abnormal swelling that might occur after the case. This is just a nice little link for a full bariatric surgery diet plan. But key to remember, they're going to be on 6 small feedings a day. Want to try to get a little bit of liquids in between there if possible to really prevent dehydration. You got to remember they have a very small area for anything to go through where they used to not have that. You want to observe for signs of dumping syndrome, and I've got you a slide in there that describes that in more detail. No pills larger than 8 millimeters can be taken because those can actually cause an obstruction in there, as well as you have to be concerned with what medications will even absorb, and they have to rethink. Sometimes the medications might need to be changed to liquid. Obviously, extended release medications may not be a good plan for somebody that doesn't have good absorption. And like I said, they've got to be on a multitude of vitamins to kind of supplement where they're not absorbing vitamins from food as well. These are some things to really make note of. You want to know the short-term life-threatening complications. These patients can have pulmonary embolism. They're very prone to infection, and they can actually have an anastomosis leak. And what that means is, in those areas where a gastric bypass has been sutured on either end, from the end going into the upper stomach, or the end that's going lower down below and connecting into the small bowel, one of those can come loose. And should that come loose, you're going to see some serious leak of gastric materials and or foods into the peritoneal cavity. Again, adding to why you really want to monitor the abdominal girth. Other long-term complications and side effects, you can have a thing where the band slips down and is not in place where it was. You can easily get obstructions in that area in the upper part of the stomach, or you can have obstructions just because of small amounts of food and not food moving along well. Patients can develop hernias. They tend to have a real big issue with acid reflux because they take in too much than what they should, and then they vomit a lot of times and have some of that come back up. Because of the vitamin deficiencies, they can develop osteoporosis and other kinds of anemias. And then dumping syndrome is sometimes common as well. And these are just some of the clinical manifestations that you would see. The stomach contents are really rapidly dumped into the small intestine. And because of this delivery of large amounts of this fluid into the duodenum, they can have lots of nausea, vomiting, abdominal pain, and cramps. They tend to have diarrhea, bloating, belching, and it can even cause heart palpitations and heart rate to go up high when this occurs. So it's just like suddenly something moved really quick and it can create some problems. So trying to watch for that. A lot of times it's like they may have to adjust some of the types of foods, or how they're eating them, or how often they're eating certain things, or it may be, they have to chew their food more or have it